yellow.
Welcome to the Prescription for Success podcast with your host, Dr. Randy Cook.
Hello, everyone, and welcome to the Prescription for Success podcast. I'm Dr. Randy Cook, and I'll be your host. Well, before we get into today's interview, I'd like to remind everyone that our podcast is produced with support from MD Coaches, a company dedicated to developing and empowering physicians and other healthcare professionals to realize a greater potential and to achieve a greater level of satisfaction in their chosen fields. You can find MD Coaches on the web at mymdcoaches.com. Well, my guest today is Dr. Benjamin Schwartz, who is an orthopedic surgeon in the Boston area. Dr. Schwartz earned his undergraduate degree from the College of William and Mary, where he was a James Monroe Scholar and a magna cum laude graduate. He obtained his MD at the Medical College of Virginia, where he was selected for the AOA Honor Society. From there, he moved to Boston Medical Center for his orthopedics residency and where he received the Lahey Clinic Residency Award during his chief residence year. And finally, he completed a fellowship at the Anderson Orthopedic Institute with an interest in arthritis of the hip and knee. After completing his training, he accepted a position at the Houston Clinic, an internationally renowned orthopedic tertiary referral center in Columbus, Georgia, before ultimately relocating to the Boston area, where he is now in private practice. Dr. Schwartz joined me for a conversation in March 2020 while the COVID-19 pandemic was in its early stages. So now let's hear that conversation. So I'm talking today with Dr. Benjamin Schwartz up in the Boston area, very busy orthopedic surgeon, or at least he has been a busy orthopedic surgeon. We are having our conversation early in the development and the management of the COVID-19 pandemic, and we'll probably talk a little bit about that in the course of the conversation. But first of all, Ben, let me say thank you very much for being here and welcome to Prescription for Success.
Yes, thank you. Thanks for having me.
Great to have you. And as always, Ben, if it's okay with you, what I'd like to talk about for a while is kind of how you got to be where you are. And that always starts in the beginning of your interest in medicine. Was that something that was on your mind early in your life, or did it develop later? Just how did that come about?
Yeah, it was relatively early on. You know, I come from a little bit of a medical background family, but not in the traditional sense, in that a lot of doctors are children of doctors. Both my parents were in healthcare, but neither one of them was a doctor. My mom was a nurse anesthetist who gave up her career to raise a family. And my father started as an operating room manager and kind of worked his way up from there.
Wow.
Worked for HCA for a while and eventually became an administrator. So kind of the other side of it. And as you know, from your career, administrators and doctors don't always see eye to eye. It can be a little bit, Hatfields and McCoys.
Yeah.
I definitely got some sense of that growing up, the clashes that my dad would have with some of the physicians in his hospital. But he was supportive of my decision to go into medicine. So
even though I guess in the more traditional sense, it would be correct to say it's not a typical medically oriented family, but yet I'm thinking with having a nurse in the family and a hospital administrator in the family, you might actually have been much better equipped for the things that you were going to face in the future. Do you think that could be true or not?
Yeah, absolutely. I mean, you see both sides of it. And as a doctor, you work closely with nurses and you work closely with administrators and you get a little bit of their perspective when you grow up with them. And my dad's only advice when I told him I wanted to go to medical school was don't be a jerk. And that's what he told me. He was supportive. He said, don't forget to treat people with respect, the people around you and realize where they're coming from. And that's something I've kind of kept with me throughout my career, and just to try to understand that everyone's got their perspectives and where they're coming from.
Sounds like he might have encountered an occasional jerk along the way. You think so?
He had his clashes, let's just put it that way. As everyone does in medicine with their area that they're involved with.
So you got yourself ready to get into your pre-medical curriculum at William and Mary, and had a pretty good run there, according to what I read about you. You were a magna cum laude graduate with a major in biology. Was that would you say that was relatively smooth sailing for you? Did you find that there were struggles in undergraduate school? What was your impression?
Yeah, my struggle was just getting there. I think like a lot of people that ended up in medicine, I had a pretty solid start in my high school career. I took honors classes, AP classes. I thought I was fairly well-rounded as a student. And so I applied to the typical big name East Coast, universities, the Ivy League universities. And I felt, and my guidance counselor felt too, that I was a pretty strong candidate. And in fact, I applied to William & Mary almost as an afterthought. It was a recommendation of my parents, as I'm sure a lot of high school students, every year apply to places on the recommendation of their parents that they wouldn't necessarily apply to. So it was to placate them because they used to go down to Williamsburg at Christmas time from Pennsylvania, where they grew up. Both of them grew up. And so I applied there, just kind of as an afterthought. And that was actually the first school I heard back from was William & Mary. And not only did I get in, I got a scholarship that I hadn't applied for, just kind of based on my SAT scores and my undergraduate or my high school GPA. So I thought at that point, I'm a shoo-in, for any of these other places I had applied to. And then over the course of the next couple of weeks, it was just, the rejection letters coming in one after the other. So it turned out it was either William & Mary or nothing, which was, disappointing, obviously, and not something I expected. Sure. Based on up to that point in my academic career. It was probably my first real taste of failure in my academic career. And not to impugn William & Mary, I think it worked out for the best. It's a wonderful school. It was more of my ignorance than anything else because I thought I got a top-notch education. I wouldn't trade that experience for anything. But it was a tough sort of episode of just getting into one college when you feel like, you have a pretty solid resume.
Yeah. And by the way, I never asked, where exactly did you grow up? Was it in the Virginia area or elsewhere? So my dad working for HCA, we moved around from hospital to hospital. So I was born in Martinsville, Virginia, which is southwestern Virginia. We only lived there for a couple of years. And we lived in Nashville, where HCA is headquartered for a few years. Sure. And then my dad got his first administration job, his own hospital in Panama City, Florida. And this was the early 80s. I think we were there for about 3.5 years. And then ended up in Columbus, Georgia at another HCA hospital where we lived from the time I was about fourth grade till when I graduated high school. So you spent a good bit of time in the South.
Did, yeah. I mean, basically, my entire life growing up was Virginia, Tennessee, Florida, and Georgia. Even though both of my parents were born and raised in Pennsylvania, that's just kind of where my dad's career took us. So
undergraduate school had its challenges. Of course, you did well. And when you looked around to pick medical schools, was it the same sort of thing? Did you feel like you had a lot of choices, or did you have your eye set on one, or what happened at that point?
Yeah, I had a few choices. I didn't apply to a ton of places. I tried to keep it to places that, I thought I would want to go and not just take the shotgun approach of let me apply to as many as I possibly can to increase my chances. Having gone to William & Mary, Medical College of Virginia, which is what it was called at that time. It's Virginia Commonwealth University now, was certainly on the radar screen because I knew it. Thomas Jefferson in Philadelphia was actually on my radar screen as well. My great-grandfather had gone there in the early 1900s and somewhat of a minor legend there. as it was his last year of medical school. He was getting ready to graduate. And for some reason, and it's not clear why, he was climbing out of a second-story window into another second-story window and fell and ended up paralyzed, paraplegic.
Wow.
And in those days, in the early 1900s, there weren't a whole lot of options. He ended up as a double amputee and wheelchair bound, and it took him about a year to recover. But he did, and he completed his classes, and he ended up graduating the following year. And as legend has it, he was the first person to get a standing ovation in the lecture hall where the graduation was held. And so he sort of became a minor legend at that point at Thomas Jefferson. And it wasn't easy practicing medicine in a wheelchair. He ended up becoming an ophthalmologist, which back in those days was pretty limited in what you could do.
Sure.
But that's what he could do from a wheelchair. And this was outside of Philadelphia in Amish land, basically, Pennsylvania Dutch land. And so a lot of the patients he would treat for trading goods and services. They would make him stuff, they would bring him stuff, or do tasks for him in return for medical care.
That's quite a story. And this was your grandfather, you say?
Great-grandfather.
Your great-grandfather. Did you have an opportunity to meet him? Did you ever know him?
No. He was long gone.
I would imagine. Yeah.
There's a book that Jefferson Medical College puts out that has some of its more notable alumni in it, and he was in there, and that's how I learned about the story. And they had in fact interviewed my grandmother for the story when she was still alive, so I knew a bit about it. His name was James Keith, but he had the nickname of Smilin' Jim because apparently he was always smiling, and even through this terrible episode, he kept his spirits up, and that's how he gained his notoriety.
That's a great story. So, let's talk a little bit more about medical school. How did that strike you? Was it more challenging, less challenging than undergrad, or what was your experience?
Yeah, for me, the first couple of years were challenging in the sense that it's a lot of coursework, obviously. It's a lot of studying. It's a lot of information coming at you quickly. But, we were in the classroom in my medical school. The first 2 years were lecture-based. And so you just kind of get into a routine of how to study and how to prepare. And I had learned very good study habits at William & Mary because it's a challenging academic institution. I was able to translate that and carry that through to medical school. So I did fairly well in the first couple of years. The third year, I think, was the bigger challenge for me, the clinical rotations and being in the hospital. And it's not book learning, it's sort of on-the-job learning. And really, you're being evaluated on, sort of your ability to draw attention to yourself, for lack of a better term. I mean, you get limited time in front of your attendings. You get limited time in front of the residents. You got to figure out, how am I going to make myself stand out? How do I prove to these people what my knowledge level is, what my ability to take care of patients is? And
not like you can study for the test, right?
Can't study for the test. I mean, you're on the spot, you're sitting there, you're on rounds and being asked questions or asked to present. And, somebody who's naturally quiet and introverted, that was tough for me. I'm not somebody who naturally calls attention to himself or is a self-promoter. And so it was hard to, maybe stand out during those clinical rotations and make sure that, people know what your comfort level is, your level of knowledge, your ability to take care of patients. So that was a little bit more of a challenge for me, who's maybe more comfortable, in the classroom environment than in that environment.
Well, do you think you formulated some kind of a plan or some methodology of dealing with that? Were you conscious that you kind of had to step outside your comfort zone?
Yeah, it definitely was. I think there's strategies, sort of more in one-on-one situations rather than in group situations, and just being confident in your level of knowledge and not afraid to speak up for yourself. And I think for introverts, it's a little bit more of a over time kind of thing of, showing what you know, showing what your abilities are, and people getting to know you rather than sort of an in the moment thing. So, maybe your first impression isn't the greatest, but over time you can kind of prove, what you're all about. And you got to do what you're comfortable with and trust that over time it's going to become apparent what your abilities are and your strengths are.
Yeah. And in the course of all that, when did you come to the decision that orthopedics is where you wanted to be?
Fairly early on. I mean, I first went to medical school thinking I wanted to do pathology, and particularly forensic pathology, because I was always interested.
Now, there's
Hardy Boys growing up. Yeah, I mean, there's quite a switch from that to orthopedics, but I was always I loved the Hardy Boys growing up. Mysteries and solving mysteries and true crime and stuff like that. And I don't know if you've ever heard of Patricia Cornwell. She's a pretty famous author. She's got a series of books. So the character that Kay Scarpetta is based on in those books is actually based on the medical examiner. Marcella Fierro is her name, and she was based at MCV, and I got to meet her in the course of interviewing for medical school. Yeah, I had put in my application that I was interested in forensic pathology, and so they took me down to meet her. And she's not exactly how they describe Kay Scarpetta in the books, but a very nice lady, very accommodating, and had a great conversation with her. And then kind of pivoted to think, well, maybe I want to do plastic surgery, but more like reconstructive plastic surgery, cleft lip and palate kind of stuff, and craniofacial type of stuff. And then, from there, it was like, orthopedics, I enjoy athletics. Orthopedics is I think, more concrete than some other areas, particularly, what I do now in hip and knee replacements. You can see arthritis on an x-ray. You can treat arthritis, you cut it out, you replace it, and you're fixing the problem, and it's very kind of concrete in that respect. So I think that's ultimately what kind of drew me to orthopedics, and in particular hip and knee replacement. Is it's treating a blood pressure, treating diabetes. The patient doesn't necessarily feel any better; they don't feel that. But you take somebody that's debilitated from arthritis, and you replace their joint, and you remember what they were like when they walked into your office, and what they're like post-operatively, and that's very satisfying, for you as a physician, but also for the patient. So it was more concrete, and I really felt like I was making a detectable difference.
So you must have had a pretty good experience in your ortho rotations as a medical student. I
did. Yeah, I mean, it was a very collegial atmosphere, and orthopedics is sort of has a reputation of being the dumb jocks of the hospital, and kind of be in that atmosphere. Although I don't think that's 100% accurate, but it's a very collegial atmosphere, and you try to have fun, and it's hard work, particularly in a large academic medical center. There's a lot of running around, seeing patients and coming through the ER and stuff like that. So you really bond together and act as a team to make sure all the work gets done.
So the decision is made, and you move on to your residency, which is, I have to get back to my notes here. This was in Boston, right? The Lahey Clinic.
Correct.
And so any surprises there? Did you get there and think, wow, I've made the right decision? Or did you start to have second thoughts, or how did it go?
There's definitely ups and downs like anything. I had actually done an elective rotation as a fourth-year medical student there, so I spent a month there. The main residency was based at a Boston Medical Center, and we had some satellite locations like Lahey Clinic that we rotated to. So I kind of knew what I was getting into, having spent a month there, and at the end of that month, they seemed to like me, and I seemed to like them. So there was some mutual interest there, and I ended up going there. And it's tough. There's ups and downs. I mean, the intern year, there was ups and downs, particularly the ICU rotation. I'm sitting there thinking, I'm an orthopedic surgeon. I'm going to be an orthopedic surgeon. Managing sick ICU patients is not going to be my forte, but it's an important skill to have. But that was challenging. It was challenging to manage these patients that had carotid endarterectomies or some other procedure, and they're bouncing up and down and all over the place. So that was a challenge intern year. And then, this was a tertiary care, city hospital, a big urban hospital. And we saw a lot of varying degrees of things. And it was very busy and a lot of work and challenging. And there's ups and downs and good days and bad days. But it's one of those things you look back on and you're proud that you did it and you made it through it on the other side.
And at the time that you entered the orthopedic territory, there were a lot of choices, a lot of different directions where you could have gone. So tell us about how you made a decision about moving on to fellowship and what area and where you went from there.
Yeah, so during the course of my orthopedic residency, I kind of firmed up the decision that I wanted to specialize in hip and knee replacements. And then I relied on the people, my mentors, my attendings that were in that field that I looked up to, that I trusted their advice to kind of give me some advice of medicine in general is a small world, and particularly once you get into your specialty and your subspecialty, it's even a smaller world, and there's connections and there's people that you trust, that trust other people that can kind of point you in that direction to say, hey, this is a great place to go to learn more about what you're interested in, and they have personal knowledge. And so I just really relied on my mentors in residency to point me in the right direction in terms of fellowship.
And as you got into your fellowship, did you have the feeling that, yeah, I made the right decision, I feel much more comfortable here, and this is going to be fine? Or did you ever have any doubts or challenges at that point?
No, I think it was a good fit. I enjoyed my fellowship, which was at the Anderson Clinic, which is outside of Washington, D.C., with a group that was started basically to treat children, like a lot of orthopedic practices were started, and went from there. But it was a great group of guys. It was a great experience. It was very laid back in terms of being able to really concentrate on learning the craft of hip and knee replacement, and not have a whole lot of other responsibilities at that point. So it was a great experience to just kind of get in there and do the stuff and be taught how to do it by some of the leaders in the field.
So that sounds like a pretty good experience. You get all the training behind you, and it's time to decide where you're going to practice, and you make a decision to return to the Deep South again. So how did you make that connection? So
I had kept in contact with one of my friends from high school, whose father was an orthopedic surgeon at the Houston Clinic, which is down in Columbus, Georgia, pretty well-known orthopedic practice in the South, started by Dr. Houston many years ago. Was considered to be the grandfather of sports medicine. He really kind of invented the idea of sports medicine and taking care of high school and college athletes. And it went from there. And Dr. James Andrews is probably one of the most, if not the most well-known orthopedic surgeon, trained under Dr. Houston and started under Dr. Houston. So a really great place for orthopedics. And so my friend from high school, whose father's an orthopedic surgeon, also became an orthopedic surgeon. And I just kind of emailed him one day and said, hey, are you guys looking for somebody that does hip and knee replacements? And he said yes, and went from there and ended up back down at the Houston Clinic in Columbus, where I'd grown up.
That sounds pretty easy. And I'm going to mention, just for the sake of helping people who might not be familiar with Houston Clinic, it is literally an internationally renowned center for orthopedic surgery. It's located in a place where you might not expect. Columbus, Georgia is not a gigantic metropolis. It's not New York, it's not Boston, it's not Los Angeles, but yet it truly is a tertiary referral center. And I'm guessing that you saw patients at least from all over the country, and probably some international patients as well. Am I correct?
Yes. I mean, you're correct. It's a very well-known orthopedic practice that we had satellite offices all over the Southeast. And you see patients from all over, and it's got a great reputation, which is great for me to be able to be associated with that and see patients from all over with all kinds of different problems who were looking for help that maybe weren't getting the answers they wanted elsewhere. And also had the ability to be around early in my career, some really great mentors, in particular a gentleman by the name of Carl Savory, who had quite a storied background. He was an Army Ranger for a long period of time and had a very storied Army career, but was really just a very well-known name in the world of hip and knee replacements in that area, but also just a great guy and somebody that didn't have to at that point in his career, but was very gracious to take me under his wing and be a mentor to me and allow me to bounce ideas off of him and encourage me, if I was struggling or applaud me, when I was doing well. even scrub in with them on some cases and kind of learn from a master how to do these things. And that was invaluable to me at that point in my career, to have somebody of that stature and that reputation and that ability be willing to take me under his wing and really treat me as an equal and teach me what he knew.
Sounds like a good experience.
Yeah, it was great. I mean, like I said, to have somebody like that earlier on in your career is very helpful when you're first starting out.
So let's take just a short break for a minute or two. I want to take a moment to talk to you about a new sponsor that we have here on Prescription for Success. Physician Outlook is a new magazine platform built for physicians and by physicians, and it's designed to showcase unique physician talents. Sometimes it might be clinical talents, but mostly it's about the intersection between clinical and non-clinical talents, whether it be writing or painting or cooking, or maybe even making a political statement in front of a state and local governing body, or even at the nation's capital, and dozens of other things. It's available online and in print. It's visually stunning on all of its platforms. I promise it's really unique in terms of physician lifestyle magazines. I think you'll really enjoy it. We think it's just the thing to fill your prescription for success. And like the Prescription for Success podcast, Physician Outlook magazine amplifies the voice of any doctor who has something to say, and also uniquely engages patients who still believe in physician-led, team-based care. And Prescription for Success listeners can get $20 off an annual subscription fee by visiting rxforsuccesspodcast.com/Physician Outlook. And now let's get back to today's interview. So it sounds like you had a very satisfying and very successful practice at the Houston clinic, but for some reason you decided you wanted to move back to the Northeast. I'm interested in how you came to that.
Well, that reason is basically, as anybody knows, that's been married is happy wife, happy life. And my wife had the fortune of being born and raised in Monterey, California, which is, I think, one of the most desirable areas to live and grow up in the continental U.S. And it's hard to compare that to anywhere else.
Yep.
And living in Columbus was a little bit of a different experience for her from that standpoint. She was also a nurse anesthetist and had done her training at Georgetown in D.C., both undergraduate and nursing school. But really just looking for to be closer to a metropolitan area, to be closer to some water, having grown up on the Pacific Ocean. And had an opportunity, still had connections up in this area from when I was a resident, to come back this direction, just to be a little bit, more with in line with what she was looking for in terms of a place to live.
And you made your way back to Boston, but there was a stop in Pennsylvania, right?
Yeah, Pennsylvania actually came first. So when I first left fellowship, I took a job close to where my parents were in Pennsylvania. At that point, I was not married, just kind of to figure out what I wanted to do. So that was a little town called Hanover, Pennsylvania, before I went to Houston Clinic. And again, at that point, I wasn't married. It was just sort of, first job out of fellowship to figure out, what I wanted to do going forward. And then from there, it was to the Houston Clinic. And
I see.
Shortly after we got married.
And then back in Boston, was everybody happier? How'd it go?
Yeah, so we've been here for almost 6 years now. And so, doing very well, happy with where we are. We live on what's called the North Shore of Massachusetts, which is about 20 miles north of Boston. And depending on traffic, it's either 20 minutes or an hour and 20 minutes to get from the city to here. But it's a great area. We're on the water. We're not too far from the water. You can be in Canada within a few hours if you want to be. You can be in the mountains if you want to be. You can be in the city if you want to be. There's lots of recreational stuff. The winters can be tough, but this time of year is one of my favorite times of year here when it gets warmer and just spring and the fall before it gets too cold are just tremendous times of year in New England.
So the living conditions are good, and I gather that your practice has been very successful up there.
Yeah, I've been very busy. I'm in a private practice. We're a decent sized private practice, but have been able to ramp up pretty quickly in my almost 6 years here, doing hip and knee replacements. And in general, I mean, arthritis is becoming more and more prevalent as the baby boomer population ages. So we're not going to be hurting for business, that's for sure.
Yeah. Well, I want to take the opportunity to see what I can learn from you about your experience in the last 2 weeks. I'll have to say, for our audience, I'm not exactly sure when they'll hear this episode of the podcast, but we are, I don't really know how many weeks into what is going to be called the COVID-19 pandemic, but certainly within the last 2 weeks, there have been a lot of changes in everybody's hospital. And I have talked to some people in the primary care world within the last 2 weeks, but you are the first specialist that I've had an opportunity to have a conversation with. So what has been the impact of the social distancing and the canceling of elective surgeries and all the other things that have been going on in this very challenging time?
Yeah, I mean, I think it's unprecedented. It's not like anything we've seen in my lifetime, for sure. And it was two weeks ago now that it was the weekend. I had operated that Friday before the weekend, and this is when things were sort of ramping up. And I just had a hunch that they were going to go ahead and decide to postpone elective cases over the weekend. And it came down Sunday afternoon where I got a phone call that, yes, we're postponing elective cases. So it wasn't a huge surprise at that point, but it's been odd. I had a full schedule of elective cases that week that were postponed, and then it was extended out another week, so those were postponed, and we had to make the decision: do we keep seeing patients in the office? Do we not keep seeing patients? We ultimately made the decision to stay open in a limited fashion to see patients that had urgent or emergent issues, post-op patients, and to hopefully keep those patients out of the ER as well that had musculoskeletal issues that we could see and manage in the office, rather than be closed and have those people go to the already overburdened ERs. And then, a week into it, then you start to worry about your business as a private practice, in terms of we're not bringing revenue in through the door, and we're not seeing patients, and we're not doing surgeries. How do we manage that? Are we going to have to lay people off? Are we going to have to furlough people? Do we not pay ourselves for a while? And it's a process and evolution. We're fortunate enough that we have a big enough group and enough reserve that, we feel like we're going to be okay for a little while. And we're seeing enough patients in the office to keep at least some revenue coming through the door. We were able to scramble and get some telehealth visits going as well, to be able to continue to treat our patients and stay in contact with their patients. And also, in reality, to bring in some revenue as well. But we're probably just now, at the time of this recording, getting into the ramp up period where the cases are going to kind of hit that upswing, and who knows, what's going to happen going forward.
So are you all doing any elective surgery at all right now?
We are not. We pretty much made that decision a couple of weeks ago, and I think it was the right decision to make for a lot of different reasons. Preserving
until we figure out what's the right.
Yeah, I mean, the resources, and then obviously we're hurting for personal protective equipment, and to try to maintain that, and to make sure that we are maintaining social distancing and not unnecessarily exposing people to each other.
And what about emergent cases? People still break their hips, fracture their ankles, that sort of thing. How has that been dealt with?
Yeah, so those cases are still going on. If they come into the hospital, we take call. So obviously, if those come through the hospital, then they're addressed. Anything where you feel like delaying the patient's care would have a detrimental effect, then you're going to take care of. So there's not a set list of those things, but there's certainly the typical things that you have to take care of in a more, I guess, time-sensitive fashion, for lack of a better word. And for anything that's on the borderline or a gray area, most of the hospitals have kind of set up a committee to say, let's review this, let's make sure that this is appropriate and can't wait. So I think there's been a pretty logical
approach to that.
And your emergency room, has it had to make adjustments so that those types of emergencies can go to a place that's away from people that might be contagious?
Yeah, I believe so. I mean, to be honest with you, I have not been on call since this started. I have not had occasion to have to go to the ER yet. So I've tried to do my part and kind of stay away to make sure that I'm not exposing anyone or myself unnecessarily.
Sure.
But I'm sure that, the steps are being taken to try to identify potentially infected people and isolate them. But I understand our hospitals are now starting to see kind of the uptick, and like anywhere else, some of the personal equipment is in short supply.
Well, I've been curious. As I say, you're the first surgical type person that I've had a conversation with since this thing started. And I think even today, well into the 21st century, emergency departments are largely unchanged from 20, 30 years ago, and that is people come through the door, and at least initially they're kind of all in one mixture of different diagnoses, and I'm curious as to whether people are able to isolate potentially infectious people from others or not. And sounds like, from what you're telling me, it sounds like they're probably in the process of still trying to figure that out at your place.
Yeah, I know one thing that the hospitals have been doing is setting up tents or roadblocks, for lack of a better term, screening point, I guess, as somebody comes into the hospital grounds to say, hey, are you here for this particular reason? And if so, then we can identify those people early on and try to get them to an area where they could be more isolated. So I think hospitals are taking those steps to try to identify people that may be infected as they come in, and to try to reduce the number of people coming through that don't need to be there in terms of family visitors and stuff like that.
Well, it's different, or a very different set of rules. I am not sorry that I am retired from clinical practice, because this is really quite a challenge, and my hat is definitely off to you and all those people who are there to deal with it, because the challenge is still there, and we haven't figured our way entirely through it at this point. So thanks to you all for doing your very best, and sounds like you really are. So what I'd like to do at this point, Ben, is to segue us into what is actually my favorite part of the program, where you get to give us some advice. So I'm going to close my mic and sit quietly while you give us your prescriptions for success.
Yeah, I think number one, one of the things that I've learned as I've gone along and maybe didn't appreciate fully at first was to seek out leadership positions early on in your career and really get involved. And I think what the definition of leadership has changed. It's not necessarily traditionally what we thought of as leadership of, say, being president of your state medical society or president of the medical staff. There's a lot of different ways to get involved in leadership and to seek those out even early on in your career to gain those experiences and get involved, whether it's free clinics in the community or volunteering with your specialty society on a committee or reviewing papers for journal articles. Those types of things, I think, are a great way to get involved, get exposure to a lot of different people in different areas of medicine, and really become a more well-rounded physician that can also give back. So that's something that I wish I'd included into a little bit earlier on in my career. I think the other thing is to learn about the business of medicine. I think it's something we don't do a great job of teaching medical students and residents right now, and it's a little bit taboo as you're in your training to think about medicine as a business. But unfortunately, whether you agree with it or not, and whether you agree with our system or not, that's the reality of it, and you're going to have to deal with it, whether you're in private practice, whether you're an employed physician, any model, there is that aspect of it. And it's, I think, important to understand that how medicine is paid for, understand insurances, understand networks and things like that do have a real impact on the way that you practice medicine beyond the clinical aspect of it. And don't be embarrassed or afraid to learn about the business of medicine to have a better understanding of the non-clinical aspects of it. And then finally, I think it's becoming more and more important, really in all areas of life and business, but even in medicine, to focus on EQ, emotional quotient or emotional intelligence. I think just about everybody that gets into medicine is intelligent, has a relatively high IQ. But I think beyond that, learning how to treat people, learning how to deal with people, learning how to interact with people is a very valuable skill that everybody should learn, and particularly in medicine. How do you communicate with patients? How do you communicate with the staff around you is very important. And I think having a high emotional intelligence or emotional quotient is something that can't be overlooked, even in medicine, where we focus on surgical ability, on your clinical knowledge. The doctoring part of being a doctor isn't just the diagnostician in you. It's not just the surgical skills, but it's also the ability to take care of patients, interact with patients, and interact with the people that are around you.
Well, Ben, that is some really profound advice. I particularly like what you said about improving your EQ. That is definitely something that is, well, you just don't get any instruction of that sort in any of your training in medicine, and yet it turns out to be so profoundly important. So thank you very much for sharing your thoughts with us. Thank you for being here. And before we go, I want to give you a chance to let people know how they can follow you, contact you, keep up with you, if you'd like to share that with us.
Sure. Yeah, I'm fairly active on LinkedIn. I think it's pretty easy to find my LinkedIn page, Benjamin Schwartz, MD. On there, I also have a website. It's more a patient-facing website, but there's an email address on there that I can be reached at. It's benschwartzmd.com. Pretty easy to get there. And like I said, there's a link to an email address that people can certainly email me if they'd like to.
Well, once again, Ben, thank you so much. I've really enjoyed talking to you, and it's good to know that you all have things relatively well under control in the hospital where you practice up in the Northeast. We hope for you and for everyone that things in that territory will improve quickly, and that you guys will be back to elective surgery very soon. But we certainly just don't know right now.
This is true. Yeah, I hope everyone stays safe and does their part to try to help us get over this as quickly as possible.
So that will wrap up another episode of Prescription for Success. But before we go, I want to invite you to visit our website at rxforsuccesspodcast.com, where you can become a subscriber. And we'd also like for you to be a part of the podcast. Just visit the website, click on the Contact Us button on the top of the home page, then scroll to the bottom and click on the big red Record button. And finally, just go ahead and read us your own personal prescription for success. If you stumble, like I do occasionally, just start over, and we'll edit to make you sound great. We look forward to hearing from you. Thank you so much for listening, and don't forget to fill your prescription for success with my next episode.